Okay, The Severely Demented, Minimally Functional Patient, An Ethical Analysis by John Arras. Mrs. Smith, an 85-year-old resident of a nursing home, was transferred to the hospital for treatment of pneumonia. Although she has responded well to antibiotic therapy, her overall condition and prognosis remain grim. For the past 3 years, her mental state has been steadily deteriorating due to a series of strokes, which have finally rendered her severely demented. She is now non-ambulatory, meaning she can't walk, incapable of sitting up in bed, and uncommunicative most of the time. When she does talk, her speech is completely incoherent and repetitive. Mrs. Smith shows no signs of recognizing or remembering her family and primary caregivers. The nurses in charge of her care assert that she appears to experience pleasure only when her hair is combed or her back is rubbed. During her recovery from pneumonia, Mrs. Smith began to have problems with swallowing food, following a precipitous decline in her caloric intake, that is, a steep decline in her caloric intake, calories she was getting. Her son and daughter, the only involved family members, consented to the placement of a nasogastric tube. Mrs. Smith continually pulled out the tube, however, and continues to resist efforts to reinsert it. All right, let's look at this. So this is the reading guide. So this should be in some form or another. It may not look exactly like this, but it should be either in the course pack or posted on Canvas. But let's look at these definitions. So a nasogastric tube is a feeding tube that goes through the nose and carries food to the stomach. So that's what she's pulling out. What we're going to talk about in a second is a gastrostomy tube, or a G tube. That's a feeding tube that is surgically inserted through the abdomen and carries food to the stomach. Okay, so one way or another, these tubes deliver calories. Since she's pulling the nasogastric tube out, the question is going to be, should a G tube be surgically inserted or should it not? And so if it's not, then essentially that means that she's being allowed to die. Okay, so the healthcare team faces difficult choices regarding Mrs. Smith's care. Foremost among them is whether her physicians should surgically insert a gastrostomy tube in spite of her aversive behavior. That is, the behavior indicating that she has an aversion to or dislikes the nasogastric tube. Mrs. Smith has neither left behind a living will, nor has she indicated to family or friends at the nursing home what her preferences would be regarding life-sustaining care in this sort of circumstance. Okay, so a living will, maybe you know, is a document that a person creates when he or she is in good health and has a clear mind. It indicates what medical procedures, including especially what life-saving and life-sustaining procedures, the person wants if and when he or she is incapacitated and unable to make decisions. So, for instance, if Mrs. Smith had created a living will at some point earlier in her life, it would explain what she wants in the situation that we just read, the first column on 938. Okay, however, Mrs. Smith has neither left behind a living will, nor has she indicated to family or friends at the nursing home what her preferences would be regarding life-sustaining care in this sort of circumstance. Okay, so again, the question is, do the surgery and give her this kind of feeding tube, the G tube, or don't do the surgery, in which case she's going to be allowed to die. Both her son and daughter have stated that she would nevertheless not have wanted a gastrostomy tube inserted and would, if she could presently decide, prefer an earlier death to being sustained indefinitely in the twilight of her minimally functional condition. In defense of this claim, they note that she has always been a very active, independent person who avoided doctors whenever possible. Okay, next, let's look at this. Okay, so I'll give you this outline. So Arras, the author, is seeking a method that will tell us what we should do with Mrs. Smith. Surgery, that is, allow her to receive this life-sustaining treatment or let her die. And just to give you a little preview, so there's Mrs. Smith. She's one test case and we're considering her because which is a good test case. We're also going to look at two other test cases, which I think are, well, Mr. Black is one, and Mrs. Jones, I forget, who's the other one? Yeah, Mrs. Jones. So in the end, we're going to have three of these examples. But so in particular, we want to know what we're going to do with Mrs. Smith. All right, so here's the way we proceed. One, so we'll read this in a second. So there are two ways of probing the patient's subjectivity, that is, what the patient wants. That is two ways of trying to figure out what the patient wants. And then there, in contrast, there's the best interest standard. So, probing the patient's subjectivity is supposed to be based on what the patient appears to want. The best interest standard, B here, is supposed to be an objective measure of what is best for the patient. Okay, so when we get into the best interest standard, Arras considers someone who's in a persistent vegetative state, a marginally functional patient, so that's someone who's in a better condition than Mrs. Smith, and then we have Mrs. Smith. Okay, and well, this isn't going to mean much to you right this second, but you might note that Arras uses the most general version of the best interest standard for Mr. Black, who is in a tough case. For Mrs. Smith, he invokes the Conroy version of the best interest test. We'll get to that later. And then at the end of the article, Arras proposes what he calls a procedural solution for figuring out what to do with Mrs. Smith. Okay, probing the patient's subjectivity, that is, trying to figure out what the patient wants. The first order of business in deciding for incompetent patients is to inquire, whenever possible, what the patient would want were she presently able to communicate. In the absence of a designated proxy or living will that speaks with rare precision about which modes of treatment are to be foregone under which circumstances, this task is more difficult than many commentators and jurists would have us think. In this context, jurists means judges. So this task is more difficult than many commentators and judges would have us think. The case before us yields two distinct sources of revelation, bearing on the patient's putative subjective wishes regarding the present decision. Okay, so we have two sources that perhaps reveal what the patient wants. The first is extrapolating from the patient's prior values, and the second is the evidentiary value of aversive behavior. This is from the present behavior, what can we figure out about what the patient wants? As we shall see, neither provides evidence sufficiently compelling for us to conclude with moral certitude that she would not allow the insertion of a G-tube. Okay, so we'll read that in a second, but here's just some notes on the first of these. Well, it's a subsection, extrapolating from the patient's prior values. So one method for deciding what Mrs. Smith now wants is to consider her previous character traits, her previously held attitudes and behaviors, and her previous values, and based on them, determine what she would want now. The particular traits mentioned in this subsection are independence and aloofness from physicians. Okay, so Arras sees two problems with this method, that is, trying to figure out what the patient wants based on the values that she seemed to have earlier in her life. First, there's a pretty big difference between a person's preferences or tastes and a person's actual choices. A person can have a certain set of preferences, but not choose for him or herself the action that would seem to follow from those preferences, or from that preference. Hence, while we should respect people's choices, we don't owe their preferences any special respect. That's what Arras says in this section. At least in this context, that's the case. Maybe there are other situations where we do have an obligation to take someone's preferences, not just their choices, but their general preferences seriously. But in any case, this is what I have here is Arras's basic point. And then the second problem with this method of trying to figure out what the patient wants is a person's character traits may suggest a desire for one course of action, but those character traits are compatible with a range of possible responses. that is a range of possible actions. Okay, we'll come back and look at this when we get to the second subsection. Okay, extrapolating from the patient's prior values. First, we have the testimony of family members who claim that the patient's character traits of independence and aloofness from physicians point to the conclusion that she would not want to be sustained by a G-tube. Although this claim may well be plausible and at least consistent with Mrs. Smith's previously held attitudes and behaviors, it would require a great leap of both faith and logic to conclude that evidence of this sort entails a negative decision on life-sustaining treatment. Okay, so she has this character trait, or these two traits, independence and aloofness from physicians. Those traits are consistent with not wanting life-sustaining treatment, but they don't necessarily mean only that she would reject life-sustaining treatment. As several commentators have pointed out, there is a great difference between the degree of respect owed to a patient's actual choices, even choices made prior to the advent of incompetency, and to his or her preferences or tastes. It is one thing to have negative attitudes towards aggressive life support, but it is quite another to actually refuse it in your own case. By doing so, a person commits himself or herself to a particular course of action, and it is this commitment that commands especially stringent respect. That's how this sentence ends here. So this parenthetical thing, okay, so by doing so, a person commits him or herself to a particular course of action, and it is this commitment, committing yourself to a particular course of action, that commands especially strong respect. And it's not mere attitudes or generalized preferences abstracted from the particular details of a situation where choices might be made. So these mere attitudes or generalized preferences don't command especially stringent respect. Okay, even if someone's generalized views about life, dependency, and doctors deserves the status of right claims, which they do not, they actually do not yield unequivocal answers to treatment dilemmas. Okay, so this is the second problem. Even if we take someone's generalized views about life, dependency, and doctors seriously, they're not going to unequivocally, that is, unquestionably, give us an answer about what kind of treatment she wants now. Supposing that Mrs. Smith was indeed fiercely independent and skeptical of the medical profession, does this necessarily mean that she would prefer death to her present twilight state sustained by tube feedings? Okay, ideally this shouldn't be a rhetorical question, but you can see that the point that Arras is making here is, even assuming that this is right, she is fiercely independent and skeptical of the medical profession, that does not necessarily mean that she would prefer death to being in her minimally functional state that she's in, sustained by tube feedings. Conversely, if Mrs. Smith were an exceptionally dependent sort of person who actively sought and followed the advice of physicians, would that mean that she would presently prefer an indefinite extension of her barely conscious existence to an early death? Okay, so again, this shouldn't be a rhetorical question, but the point is, even if Mrs. Smith was exceptionally dependent, she still might not want an indefinite extension of her barely conscious existence. She might want an early death, despite being exceptionally dependent. Okay, so although such character traits indisputably have some evidentiary value, that is, some value as evidence, they appear to be compatible with a range of possible responses. In Mrs. Smith's case, it is certainly plausible that she would decline the insertion of a G-tube, but that is not the only plausible interpretation. For all we know, she might have been content, were she miraculously lucid and communicative for an instant, to accede to the operation, that is, to agree to the operation, rather than go peacefully into that dark night, that is, rather than die. The question for Mrs. Smith's caregivers then, and we shall explore this point more fully later on, is not whether her loved ones have provided a uniquely correct extrapolation of her previous values to her present situation, for in most cases that will simply be an unattainable goal. Rather, the question is whether their plausible invocations of her values and character traits should be given the benefit of the doubt. Okay, so this last part here, how they see her values and character traits should be given the benefit of the doubt. Arras is going to discuss that later in the article. But right now, the second method for trying to figure out what the patient wants, the evidentiary value of aversive behavior, that is, the value as evidence of behavior that indicates that she doesn't like the feeding tube. Okay, so again, let's look at this first. So now we are considering the patient's present behavior, in Mrs. Smith's case, pulling out her nasogastric tube and attempting to determine what she wants based on that behavior. So according to Arras, Mrs. Smith's behavior might be indicating any one of three things. First, it might be indicating a desire to forego aggressive life-sustaining treatment in favor of an early death. It might be indicating a sign of a deeply sedimented personal desire, that is, a deeply ingrained personal desire, such as a dislike for feeding tubes. Or it might be indicating an elemental reflex, that is a basic reflex, signaling only her transient irritation from the tube. That is her just passing irritation from having the tube in. Well, passing or temporary. All right, so Mrs. Smith has been constantly pulling out her nasogastric tube and waving off the attentions of her caregivers. What are we to make of this behavior in contrast to the patient's previous preferences and attitudes, which are ill-matched in their generality to the concreteness of the present situation? Mrs. Smith's aversive behavior at least has the advantage of being contemporaneous. That is, this behavior indicating that she doesn't like the feeding tube is happening right here in the present. She is extubating herself right here and now. According to Daniel Callahan, a philosopher who generally sees no justification for terminating food and fluids in severely demented patients, such behavior constitutes a clear signal mandating withdrawal of the tube. But a clear signal of what? It is crucial to remember at this juncture that Mrs. Smith is severely demented and completely incompetent. Even though her aversive behavior occurs in the present, it is the behavior of a woman who has completely lost her rational capacity. She cannot even recognize her family, let alone engage in sophisticated deliberations bearing on the respective benefits and burdens of continued tube feeding in her minimally functional state versus an earlier death. Aphasic but otherwise competent patients, so aphasic means the patient's unable to speak or understand, but otherwise he or she is cognitively intact. So these patients, aphasic but otherwise competent patients, might be able to send clear signals under such circumstances, but not Mrs. Smith, whose behavior appears to be freighted with a variety of possible meanings. That is, her behavior seems to carry a variety of different possible meanings. It is possible that her tube pulling represents a firm and fixed present desire to forego aggressive life-sustaining treatments in favor of an early death. Okay, so that's the first possibility. It is also possible that it signals some kind of deeply sedimented personal desire manifested in spite of her present incompetence. That is, deeply ingrained personal desire. 3, it is equally possible that her aversive behavior is nothing more than an elemental reflex signaling only her transient irritation from the tube. Nasogastric tubes are bothersome and sometimes painful intrusions, and one need not entertain sophisticated benefit-burden calculations to wish merely to be rid of such noxious stimuli. Thus, the interpretive options range from deeply intentional options for death in the face of minimally functional existence to reflexes of an almost exclusively physiological nature. Okay, so we're interpreting her behavior, and as Arras says, it can be interpreted in quite a wide range of ways. Mrs. Smith's signal is thus anything but clear, and this is a significant fact for her caregivers to ponder. While aversive behavior expressive of deeply ingrained personal values, should be accorded the same degree of respect allotted to general character traits and attitudes. Aversive reflexes to unpleasant stimuli should command little, if any, deference from surrogate decision makers. Small children extubate themselves all the time, but no one would view such actions as a clear signal of a wish to die. The real problem facing Mrs. Smith's physicians is that they have no reliable way of discerning the real meaning behind her ongoing resistance to feeding tubes. It would certainly help if Mrs. Smith had been known to shun feeding tubes even while she was competent, for that would at least provide some plausible evidence connecting her presently aversive behavior to ingrained preferences, but in the absence of such a record, the meaning of her rejection remains profoundly unclear. Given the inconclusiveness of this inquiry into the patient's previous attitudes, that was what we read in the first subsection up here, and present behavior, that's this subsection, her caregivers might reasonably shift their focus of attention away from the patient's elusive subjectivity and toward a more objective assessment of her best interest. Okay, so just finally, to show you this. What is Arras's conclusion for this section, probing the patient's subjectivity? Basically, the two options we looked at, are not good methods for determining what should be done with Mrs. Smith's care.